Alrighty, so looking at our presentation, the team from St. George's, we are just on one site, and we've got about 150 children on our caseload, and then this year we've got a tally of about 19 new patients, and interestingly, quite a handful of them have been type 2 patients. We might need to be thinking about looking into that as well. With regards to our poster, we are just going to be focusing on our newly diagnosed pathway, so not too dissimilar to the presentation from Wales. What we achieved were from our first QI meeting was our aim as a team, and I think that's maintained to be a focus that we continue to draw back to. And what we agreed that we wanted to look at for our areas of improvement were additional to the newly diagnosed pathway, the high Hba1c pathway, and also eventually looking at our pump pathway. But today we're just going to look further into our newly diagnosed process. We completed our fishbone analysis at the start of the year, and as we've all learnt, this is a very kind of useful tool in enabling us to see which areas we want to focus on and where we need to get people on board. And the causes were sort of hospital-wide. We identified that within our team we had some communication areas that we could work on. We were also having difficulties with supplies and having equipment available in a readily manner. We also knew that we needed to get the ward staff and the wider hospital on board, and really starting with the A&E and emergency department, and then also right down to the patients and a little bit of organisation around their availability and the use of interpreters and things. So what we knew was happening was, well, what we thought was happening was our patients were getting quite a disorganised interpretation of how our team worked, and we wanted to ensure that from the get-go they knew that we were able to deliver an excellent level of care. So the driver diagram is also another very useful tool that we have been able to kind of nail out which areas would work with first and what tools we're going to use to improve those. So we then kind of came up with our final ideas and changes that we were able to implement, and it was things from as simple as getting the prescriptions correct, thinking about how we were communicating and arranging a team huddle, developing checklists which we've been able to have for ourselves as a team, the ward staff, and also for the patients and families to be filling out. We've got together all of our equipment in an orderly manner and have thought about doing a lot more education within the trust with from ward nurses to A&E staff. So our improvements so far, sort of January, we were able to get the kind of the easy stuff done with regards to arranging the new patient information folders and getting them all ready for use. We thought about questionnaires and getting feedback and trying to gather some results and audit data. In February, obviously with the nature of the COVID-19, our huddles became quite impossible, but we were able to get ahead with our IT system at St. George's and get an electronic checklist sort of uploaded onto the patient's notes so we could have that clearly ready for our team and for the ward staff to be using. In April, we sort of started looking at the patient-centred checklists and their competencies around their improvement and their confidence to be discharged. We've since enhanced that because we did just used to have paper copies. We've now got that electronic and able to send it to email to families immediately after their stay with us, and we've got a lot more responses back, which has been useful. And then this month we are looking at having a debrief within part of our usual team meeting where we reflect on the admissions that we've had recently, and that also enables us to complete our feedback from health professionals and just make that all a bit easier. So the interventions that we've looked at sort of as a whole, as I've already discussed, we have kind of moved through, and I guess when we think about the process of change, it's making sure that we make the changes significant but easily noted, and then also being able to maintain them. So it's keeping on top of the fact that we've have the resource packs ready for use, and we've always got a certain number sitting in the cupboard. And as we've learnt with COVID, that getting things online and electronic makes everything a lot easier as well. This is a bit of a busy slide, but it's just sort of highlighting what are the resources that we have been able to develop. We're very lucky because we've got a super creative psychologist in our team and makes information sheets that are interesting and have all the right useful information on them available for our patients. And again, we've been able to mobilize a lot of this onto the DigiBeat app that our team has adopted as well. So giving it to families in hard copy form, but also having it more readily available electronically. And I think, you know, it helps with our communication within the team as well. If this is at the patient's bedside and we're able to visually tick off duties and competencies as they're done and fill it out with the family so they're part of the journey, which has been nice. Okay. With regards to our outcome data, I think, you know, throughout our QI process, it's been highlighted quite a few times by our team that we kind of do struggle with the data side of things and collecting the right information or sort of prioritizing trying to get the right information back. What we've got here is a bit of a summary of our professional opinion of how we think things have improved around the newly diagnosis process for our patients. And you can see in January we're kind of feeling about a 5.5 out of 10, and we're kind of edging that up towards 10 by the end of this year, but there's obviously always still room for improvement. Our Hba1c data probably isn't as clean as Wales, and I think, you know, it's something that we will continue to work on within our trust around ensuring that we get that Hba1c down as quickly as possible for our newly diagnosed patients. And certainly something we'll look at collecting and analysing in a bit more in depth. Some further qualitative feedback just from families and staff has always been quite positive from the families, which is useful, but then I guess they don't have it much to compare it to, so it's reassuring, but again we need to continue to look at that improvement in their Hba1cs. Some of the bright spots that we've seen through our journey, we have patient-friendly resources now. We are definitely feeling more coercive as a team and are working well together with improvement in communication. And I think within our team, we also have a drive to continue to improve and keep up the work that we have completed already. Further actions, again, this is more just general feedback from the team and just ensuring that we are keeping on top of training and also improving consistency across the team with ensuring that we always follow the processes and it's just friendly reminders if people haven't, and continuing to debrief post-discharge in our team meetings to ensure that we get those evaluations back. And our final slide is just thinking about continuing our journey on our newly diagnosed pathway, maintaining it for the patients to come in the future, and then also thinking about getting into our high HbA1c pathway alongside to improve that, and eventually working into our pump pathway, which all seem like big projects, but with the tools we've learned from QI, we can sort of knuckle it down and make them more achievable.